Can you see?
Yes, I can say it.
Okay, perfect. So, first of all, good morning, good afternoon, or good evening to everyone, depending on the time zone you are joining us from. So, the first of all, I would like to thank you, all of you, for attending this webinar, and also thank Smartee Academy and Angela for the organizing this session. And I truly hope that it will be enjoyable, useful, and that it meets your expectation. So the main purpose of today's webinar is to help you to better understand not only the Smartee system and the different tools it offers, but also the protocols and clinical decisions that normally I personally use when explaining to the patients or to the parents in cases of growing patients the advantage that Smartee has compared to the other brands on the market. So uh, the first it's very important sometimes to when we need to explain to the patients like the first is the advantage of the Smartee is not only to focus its marketing aspects because for example the Smartee is the only brand that has a Disney license agreement, the AP, which of course was all we know is not inexpensive. That is sometimes something for not every brand can access. So this is one of the best important things because the patient come to your office and you know you have this Disney package is because this is a very important brand. So and sometimes many patients, for at least here in Spain, when the patients come to our clinic asking especially for an Invisalign treatment, it sometimes become when they actually mean is that they want to treatment with clear aligners or invisible orthodontics. So the reality is like the patients are usually unfamiliar with the proper terminology, and they commonly use the Invisalign brand name because it was the pioneer in this field, and he's remained strongly positioned in people's mind. But sometimes we need to. Sometimes the people come I want Invisalign treatment. They don't want Invisalign. They want a clear aligned treatment. So this is very important. Okay. The second important thing for today is we are going to compare like the different features between Smartee and Invisalign, like to compare like this for the marketing and of course to explain to the patients. The first of all, of course, is for me is like the aesthetic. Why? Beyond that, normally when we should try to the patient, the one of who makes the final decision. That is very important. It's very important. Why? Because normally we know the Smartee aligner is very clear. It's very clear. In fact, that picture I take that picture yesterday. So normally I prefer for this reason after having I use a lot of time. I have used Invisalign for many years, but one of the strategies that I use is to let to the patient compare the aligners themselves rather than me telling them which is one is better. Because I usually give the patient the examples, the both, the aligner, the Invisalign aligner and the Smartee aligner, allow them to examine to the patient, and I ask a simple question: which one of these two do you think or do you find more aesthetic? And in my experience, 100% of the patients choose always a Smartee. In fact, you can see here this picture. So the clear line that the Smartee is more beauty, is more clear than the Invisalign. So this is one of the things that I use is give to the patient, and the patient is taking the decision. You are not selling the treatment. Normally, you are going to the patient to choose like that one. So um, the Invisalign, you can see the liner have a certain surface rawness, which over time tends to retain more plaque and staining. Sometimes if the patient is taking, especially with the patient is frequently drinking coffee or tea. So as the liner tend to discolor more easily, you can see this picture. So, and in contrast, the Smartee liners appears more clear and more aesthetic. So this becomes a very powerful communication tool because instead of those of us imposing the choice for a patient, we allow the patient to make the decision themselves, and patients consciously choose a Smartee. The other very different with an Smartee and Invisalign is the different kind of solution. Of course, in a Smartee you have a lot of different solutions for the transversal plane, for the habits, for of course for myofunctional trainers, for transversal discrepancy, sagittal discrepancy, vertical discrepancy, and so on, everything. So this is another important aspect that differentiates Smartee from the competition. So is the wide variety of the tools and solutions that we have available. So it's not the purpose of this webinar to explain each one in detail, or to present a different clinical cases, but this to see different solutions. The another very difficult, very different we have is like in Smartee we have three different kind of templates, like and in Invisalign this only have one standard template. We know that this standard template normally we have problem when we remove like the template in the posterior area, normally in the molar we have this when we remove with the attachment, normally a lot of times is filling out with the template. Right now in the Smartee we have like the standard template, we have the software template, and the acid attachment template. So the acid attachment is specific to exactly to put the acid in the exactly area, in the exactly zone when it's the attachment. So if we compare like the Smartee, like the Kinder package or Teen package, of course we have two different big things. The first of one is the Smartee Kinder is special for prevent and intercept problems. So in that case we have 2 years of management, which of course with unlimited aligners, with unlimited refinements, and we have 2 years of management. 2 years normally is 2 natural years, and that's included as well 2 sets of retainers, 2 sets of retainers. The Smartee Teen for me is one of the best package in Smartee because we have 5 years of management, but it's 5 years of management, not natural years. What it means that, for example, in the difference between a Smartee Kinder and a Smartee Teen, you can see here, the solutions are similar in both packages, but the only difference be if we want to make the mandibular repositioning or, for example, mandibular advancement, we need to choose always the Smartee Teen. So what happened, for example, I have a patient with, for example, 7 years old with a very class 2 malocclusion, with a very big retrognative of the mandibula, and I want to make this mandibular advancement. So my package at that case is a Smartee Teen. But in another branch, you have 5 years of natural management, or 5 years of treatment. So what happened? If my patient start the treatment with 7 years and I start to move this mandibular forward, and normally it's like 1 year, 1.5 years of treatment, and I need to wait to the patient to finish to change all the teeth. So normally the patients finish around 12 years, something like this. 7 plus 5 years, in 12 years, I have my end of my warranty. But in Smartee, it's not like this. In Smartee, it's 5 years of management. So, for example, I started 7 years. So I make this mandibular advancement. I correct this sagittal problem. I make the patient from the transversal. So really good occlusion, really good. And at 8.5 years, 1.5 years of treatment, I can pause the treatment. So I pause the treatment. So I wait for the patient to change all the teeth. And when the patient have 12 years old, I can to reactivate the treatment. So if I use of my 5 years, I use 1.5 years. So I have another 3.5 years of treatment. So I can to reactivate at 12 years and to start with the correct. So I have both the prevent or intercept the first phase and the correction treatment for the second phase. So it's not 5 years, it's in natural years, maybe 7, 8, 9 years old. So I have between this year 3 until 16 years old, I can to start the treatment, I can pause the treatment twice, so and reactivate. So my maximum age is 17 years with 364 days. So the day before the patient they had the birthday for the 17 years. So this is very, very good and a very different package from the other. Okay, so this is all the solution. Of course, we need a special webinar with 2 or 3 hours to explain every kind of solution in detail, but I want to explain you a little, someone. So the clear aligners, in this case, the Smartee Teen Kinder, we have like the clear aligner, of course, the myofunctional trainers, these are very different. We have 3 different kinds of myofunctionals, and the attachments. The attachment in the Smartee Teen Kinder is special attachment because it's 40% less, because it's specially designed for kids, for this small crown teeth, for the baby teeth, and have better expression of the orthodontic force. Another different tool is the aligner trimming protocol. This is very useful because, for example, in a Smartee, we can, in growing patients, in teen and kinder, we can ask this high posterior trim line. And this is very useful, for example, in cases for expansion, because we have this cover more on the crown and the gingiva, the expression of the expansion is higher compared with another systems. And of course, it's more predictable, and we avoid this typical losing torque from the other brands. So this is, in fact, in all my cases in growing patients, I ask always this high posterior trim line. The another features we have is like the tongue protrusion and tongue trip. So in this case, for example, these devices is, for example, like the tongue protrusion device is especially indicated, for example, for patients with abnormal swallowing habits, where the tongue encounters the spherical protrusion and naturally position itself in that area, so helping to re-educate the patient to swallow correctly. And the other, the tongue trip, is the consisting of small pyramidal structures located on the lingual surface of the incisors, and this solution is especially useful for tongue interposition habits, meaning cases in which the patient tends to thrust the tongue forward. Okay, with the mandibular repositioning device, we have the 3 different. So the mandibular advancement is the HH solution, and here we have two different kind of devices. It's like the HHTV, is stream block devices, and HB. What is the difference? So the professional organization, like the philosophy, is when we have a patient that have an increased overbite, of course we have an increased curve speed, we need to use twin block appliance. And when the patient have, for example, a normal overbite and flat curve speed, the indicated is the HB. HB is Herbst. It's like Herbst. In the mandibular repositioning device, for example, we have the 2 different, like the bite 9 is bite plane, that one. And we use that one to create a vertical space for a deep bite or deep overbite. So in that cases, that patient have a very increased deep bite, deep overbite. With this kind of appliance, we have this anterior contact, and we have 2 different kinds, anatomical or non-anatomical. The anatomical, the anterior bite plane is flat, so the mandible is free to make the movement for everywhere. So this is the non-anatomical. Sorry, the anatomical is where, for example, you want to say to the technician when you want exactly to put the sensor in exactly position. So in the biplane, you have the position for the incisors. So this is especially, but it's indicated in brachyfacial patterns, for example, of course with deep overbite, and we can help for the intrusion of the anterior teeth, and of course you have this posterior disocclusion, this posterior open bite, so it helps us for the extrusion at the posterior area, and with this we can level the curve of SP. For the other part, the occlusal spleen, in that cases is special for cases when we have this mandibular deviation or facial retrognathing cases. It's like the same to say like near front classroom malocclusion. In fact, right now, I have a patient with 16 years old that have a problem with the mandibular deviation. So when the patient is closing, they have deviation to the right, but the patient will start to open, like the condyle, they go to the central relationship and the mandibula is going in the right position. So I need to take this solution special for the reprogram the mandibula. So it's very useful for that kind of cases. We have the S11, the palatal devices. In the Smartee, we have the S11 palatal devices. We have 3 different kinds. So we have like the clear arch expander, the clear nance, or the clear transpalatal bar. So the first one, the clear arch expander, you can see at the video, is to help us for the expansion. In that case, is for example that we have like the maybe unilateral or bilateral crossbite, or maybe a compression of the maxilla. So we can use that one. Normally is for more for dentoalveolar movements. It's not for skeletal. But of course, I have patients. In fact, I'm going to show you one in-depth case with 9 years old. But normally I use in patients like between 6, 7, 8, 9 years old. Of course, I think it's not properly to say that we have that skeletal results. It's very complete to explain because I need like CBCT to demonstrate it. But of course, in my opinion, we have near to have to achieve this skeletal expansion. Okay, of course, in growing patients in ages between 6 to 9 or 6 to 10. Okay, if we have more than 10, 11 or 12 years old, sometimes if you have a posterior crossbite, normally I prefer to use from the beginning like the Hyrax for the rapid palatal expansion, and when I finish with the Hyrax, for example, or McNamara, it doesn't matter, I remove this appliance and I start with my Smartee Teen or Smartee Kinder devices. So the other solution is the clear nance. So the clear nance, for example, is this solution is special, for example, to assist like the distalization of the posterior teeth. So, for example, imagine you have a patient that you want to make a distalization. Normally, we use like the anchorage. We'll use like elastics. It's like the inter-arch anchorage. You use elastics. In this case, for example, class 2 elastics. But sometimes the patient have no compliance with elastics, and we need to use like the intra-arch anchorage. In that cases, we can use this solution because like you can see at the picture, the clear nance is like they conform from the canines until premolars, and you can start to distalize the second molar. When you finish to distalize, or the second molar is the 50% of the movement, you can start to move the first molar. And when you have the second and the first molar in the final position, you can remove the clear aligner, the clear nance, and you can change for the clear transpalatal bar. This clear transpalatal bar is to, in this case, to make the anchorage of these first and second molars, and you start to retroincline or distalize like the anterior teeth. So you can combine both systems. The clear nance is for anchorage, and this anchorage for the distalization of the posterior area, and the transpalatal bar is for anchorage in the posterior area to help you to the retrusion of the anterior area. Of course, we have another solution that I think Smartee is the only brand that have 3 different kind of traction devices. So we have like the traditional one, like the bonded button, and we have the Smartee hook. The Smartee hook is like the integrated in the liner. So the Smartee hook normally is in the buccal surface of the teeth. You can choose in which teeth you want to put this Smartee hook. It's for use for class 2 elastics, class 3 elastics, or even in that cases that you're using like tabs in the posterior, in the anterior area, and you want to, for example, to use elastics to the intrusion of the anterior teeth. So in this case, you can use as well this Smartee hook, but always is in the buccal surface. The only thing is not, you can use at the same time this Smartee hook and attachments. You can put the attachment in the lingual surface on the other surface, but not in the same. And the Smartee button is like it's different because it's not bonded button like the other brand, so it's integrated in the liner between teeth. So normally in the interspace between teeth. So you can use like attachments in the buccal or lingual surface, and this is, for example, for class 2 elastics or class 3 elastics. So different at the end, the effect is similar, so it's different kind of devices. So at the end, we have 3 different kinds of integrated traction devices. And of course, we have the S16 solution. The S16 solution is like the combination from the S15 is the Smartee button, the S11 is the palatal device, and sometimes to integrate the S10 is like the posterior occlusal spleen. So at the end, the ideal is to have this for patients that have class 3 malocclusion and have this engagement of the maxilla of the interior teeth. So you can, at the same time, you can to make the, for example, with the S10 solution to make the disocclusion of the posterior area. With the S11 solution, you have the anchorage for the traction, and the S15 of the bottoms, normally they are mesial or distal of the lateral incisors, and you can use the fascial mask. And this fascial mask makes the first to make the traction of the maxilla. So it's indicated, of course, in cases with class 3 malocclusion of maxillary retrusion. Those are the indications, especially for the Smartee Teen and Smartee Kinder. Of course, like the regular clear aligning, the ideal is to use more than 22 hours per day. This is the ideal. Of course, I always say that in adults, for example, I don't negotiate with my patients, with my adult patients. So it's mandatory to use 22 hours per day. This is mandatory. In growing pains, it's true that the bone is soft, and sometimes using less hours than adults, for example, the effect is better. But I prefer always to say to the patient, use 24 hours. That sometimes maybe the kids are, sometimes they forget it, or they forget at the backpack in the school, something like this, when they go to lunch. Using less hours for me is more effective, but the ideal is 22 hours. The wear duration is different. So in my protocol, I have my first treatment, my first package of aligners. I have less than maybe 20 aligners. I prefer to change every 10 days. Until 20, 30 aligners, I prefer to change every 10 days. I have 34 aligners or plus. Normally, I prefer to change every week. Why? Or every 7 days. Why? Because normally, when you start to move the teeth, if you have less aligners, you have more movement per teeth per aligner. You know that normally, like the algorithm that most of the brands use to move the teeth, normally they move 0.25 millimeters per teeth per aligner. 2 degrees of torque and 1 degree of rotation, or maybe 1 or 2 degrees of rotation. So at the end, if you have less aligners, you have more movement per teeth per aligner. If you have more aligners, normally you have less movement per teeth per aligner. So this is why in my protocol, I change like the wear duration. In mandibular repositioning, it's similar. Normally, in mandibular repositioning, when you ask for a mandibular advancement, you can see like the first 3 or 6 aligners is for the mandibular repositioning for the myofunctional adaptation. So what happened? So you have 2 aligners, A and B. So for example, 1A, 1B, 2A, 2B. Normally it's between 3 until 6 aligners. So these kind of aligners, I prefer to change every 10 days. So it means normally I change like the A, use A 5 days, B 5 days. So changes. So this is 6 aligners. At the end is near from maybe 2 months. When you start liner number 7, is a start line when you start to move at the same time mandibular advancement, and you at the same time start to move the teeth. So at that time, I start to change the aligners every 7 days. And the myofunctional trainers, of course, this is different because I don't want to explain this because we need a lot of time to this myofunctional, but the Vite is a special device for the lips, for the tongues. It's 3 devices in one. So the ideal is to practice around 3 to 5 times per day. And the Smartee is the typical like oral screen, and normally is used during night time and 3 to 2 hours per day. And the Joy is similar like the MyoBrace appliance. So in MyoBrace appliance, the ideal is using like the nighttime as well with the Smartee, and during the daytime during 2 to 4 hours each day. So this is the first part, is to explain that how different solutions we have in Smartee to help us in our treatment. Right now we have this clinical case. So in this clinical case, it's very important, for example, we can see, I always say that this patient, when they start to smile, start to open, you have this chin that you feel like, I say, like a smell, no? Smell a class 3. And the patient is like, you can see like the intraoral pictures, you can see that effectively we have it's not a class 3, not big class 3, but we have in the right side, we have a posterior crossbite, all the right side. We lost the premature teeth of the tooth 52, and in this kind of cases, it's very important. The first of all, the diagnosis, and of course, it's very important. In this case, like the myofunctional. With the myofunctional, normally when we have like the unilateral crossbite, normally this side, in this case is the right side, is the chewing side. So this is like the patients normally is chewing from the right side. So we say like the working side. It's very important because we need sometimes not only to correct the malocclusion, of course. So sometimes we need to correct like the chewing. We need to teach to the patient how to start to eat or to chewing from the other side. This is like the pre-treatment of the intraoral scanner. Of course, we extract the tooth, the 62, because it's like they have a lot of movement, and we prefer to extract before we start the treatment with aligners. And here, for example, in the orthopontomorphy, you can see the difference between the condyles from the right and the left. What happens? So it's very important to take into consideration that this patient presents that different condylar trajectories. As you can observe, for example, in the right condyle, for example, the right side, is the side of the posterior crossbite, corresponds to the working side. So meaning like the preferred chewing side. Meanwhile, in the left side is the non-working or the balancing side. So for this reason, the right condyle, the trajectory is more vertical, whereas in the left condyle, the trajectory is more horizontal. So it's very important at the end to have this bilateral. The idea is the same condyle trajectories. Okay, we can see like the teleradiography, and here we can see for me, one of the most important, all of the measures that we have in the different cephalometrics. For me, the most important when we have a patient is class 3 or near class 3 is the vertical width. The vertical width is very important because you normally know like the A point, the ideal in that vertical is contact with the B point or maybe a little more forward. So in that case, the A point is backward of the B point. So this is a class 3 malocclusion. And this is like the arch in the upper. This is like the width of the intercanine and intermolar from the beginning in the upper and in the lower arch. So what's my treatment plan in that case? So my treatment plan in that case is important. Like, for example, I need to understand that the first, I think I know we have like the class 3 malocclusion. So we have a class 3 malocclusion, no big class 3 malocclusion, but the small class. For me, it's very important, like not only the arch expansion, transforming the arch form. So here you can see I'm using two different kind of devices. In fact, it's one devices. So it's with two. It's the S16. The X16 solution is including the S11, is this palatal. You can see here this palatal device, the S11, with the S15. In that case, the S15, the Smartee button, are located distal to the baby canine. So here we are doing like the expansion of the maxilla, and at the same time, the patient is using the fascial mask during nighttime. Why? Because it's not a big class 3. In this patient, for example, has a big class 3 malocclusion with an anterior crossbite. Maybe I ask to the patient to use the fascial mask not only during nighttime, so during at home as well, not at school, because it's very complicated right now with the new generation. You see the facial mask or something like this during school is complicated for social reasons, but it's very important to use like during nighttime and maybe a few hours at home. At this situation, exactly in that case, I ask to the patient only to use during nighttime. Okay, so this is like the patient in the liner number 27. So you can see here. And not only are we using these two devices, that one, the S11 and the S15. The another solution that I'm using is not a solution, this is a feature that we have in the Smartee. You can see here is the posterior high trend line. That solution is very useful. Why? Because one of the problems that I have with another brands when I use is when you try to make the expansion, if the material is softer than the others, or do you have this scalloped framing, the problem is you lose a lot of torque. So the problem is do you want to make this kind of expansion? So at the end, your results, you have this palatal cuspid is gone down and you have losing torque and posterior open bite. Within a Smartee, the material is little higher, so it's better for the adaptation. And of course, if you ask for this high trend line, what happened? You cover the teeth, and normally, like the baby teeth have a small crown, so normally normally if you don't put with another brands, you put a lot of attachments, or you need to maybe use attachments not only in the vagal surface, sometimes in the vagal surface as well, to have more retention. When in the Smartee, it's not necessary to use that. Why? Because you have the high trend line in that case with the attachment, and of course as well for the S11 solution, the expansion transpalatal bar. So all of these solutions make me very predictable treatment. So you can see in 27 aligners is like 27 weeks, it's near from 7 months, something like this. So this is like my situation in line number 27, and this is my Smartee check. So you can see like the predictability of the software with the real situation is higher. So this is like the art from the beginning, sorry, from the liner 27, and you can see that I correct the posterior crossbite only using the aligners with the S11 solution, with the S16. But in that case, the expansion is using to the S11 solution, not using elastics, crossbite elastics, not using like the crossbite elastics, of course, with not crossbite buttons. So only with the aligners, only with the biomechanical. So expansion, we can use, for example, I use in that case, I use the bilateral expansion, but sometimes you can use, if you want more predictability, you can use the intra-arch anchorage. Intra-arch anchorage is, for example, you can do in this case, for example, the right side don't move from the beginning, and you start making the expansion of the right side, and when you finish to correct, you start to expansion at the same time. In that case, I prefer to use the bilateral expansion from the beginning. Of course, more expansion, or in the left side is more like more slow expansion, and in the right side is faster expansion. Faster expansion is the maximum expansion. It's 0.25 millimeters, not 0.5. It's not possible. It's maximum 0.25. So in the right side is 0.25 millimeters for each aligner, but in the left side, I say to the technician, okay, in the left side, make the movement around 0.50 millimeters, for example. So you're doing this bilateral expansion, but asymmetrical, more in the right side. So right now we have the midline is centered right now. We have a space for this permanent lateral incisor, where right now they start to erupt. And here is like the scanner of the patient in the liner 27. Okay, and what happened with the intercanine width and the intermolar width? So you can see here, like the intercanine width, we increase 6.7 millimeters, so near from 7 millimeters. And this is very predictable. Why? Because the bone of the kids is very soft. So it's very ideal for this kind of treatments. So what happened if that patient came to my office maybe 15 years ago or 20 years ago, what should be my treatment plan? Maybe mm, expansion plates, maybe quad helix, maybe hyrax, but not hyrax doing this faster movement, not 2 rounds per day. Sometimes only maybe one even 2 3 days, something like this. So it's different at the end. When you have this expansion, what happened later? You need to put some braces to maybe to close the space, because when you use the hyrax, for example, you open a very big space between teeth. Is normal because you are open like the palatal, so the palatal suture. So right now, at the same time, we're openly like the dental-alveolar, the expansion of the dental-alveolar bone. At the same time, we can move teeth. So for me, it's ideal. In fact, right now, all my cases, all my first phases, all my intercept cases, I start all my cases with aligners, all my cases with Smartee, all my cases 100%. And it's, for me, is one of the best things that we have in clear aligners, is like that one, the solution. Of course, for adults it's really good as well, for the aesthetic, for the hygiene, of course, but in kids it's amazing. And for me, in my experience, the compliance and the confidence for the patient, for growing patients, is better than in adults. And this is like the morphine from the beginning, from aligner 27. In the lower arch, of course, in the lower arch, I need to make expansion as well. Why? Because I have crowding. So that case, I increase like the intercanine width, of course, less than the upper arch. So the intercanine width around 3 millimeters, and intermolar width around 1.7 millimeters. And this is the change between the beginning and the situation aligner number 27. Okay, this is the orthopomorphy. And what you can see here, what the big difference, not only for the space for the lateral incisors, what happened in the condyle trajectory. So right now it's different. Why? Because we have like right now in both sides, it's more horizontal, it's similar. So we are creating, in this case, we need to make this bilateral. This is bilateral chewing. So it's very important. So in the patient, it's not only the treatment plan, of course, like the protocols, the expansion, using the liner. So at the same time, when the patient is removing the liner for the meal time, I always say to the patient, you need to chewing from the left side. Everything from the left side. You need to start. Why? Because we need to create this bilateral occlusion. So right now, both condylar trajectory are similar. Okay, and this is the
Headshot. Which kind of headshot?
Sorry, can you move like the microphone, please? Okay, thank you. What happened, and this is one of the unwanted effects when we use a facial mask, and maybe if I treat this patient right now, but because it's not a mistake, but this is like the unwanted movement. What happened when you are using like the facial mask? When you start to use the facial mask, what happened with the upper incisors? The upper incisors, they have the tendency from the to pro-incline, and in fact you can see the difference. I have more pro-inclination of the upper incisors. So if I treated the same case right now today, maybe I use another solution that we have in the Smartee, is the lip bumper solution. The lip bumper solution is integrated in the liner, so it's to optimize the anchorage and of course to improve the anchorage, and we can use in the lower and in the upper arch as well. So it's to improve the anchorage and to prevent the pro-inclination. So for example, in my cases with mandibular advancements, of course, to say 100% of my cases is complicated, but I have from the beginning, I have my lower incisor is straight or little pro-inclination. I normally always use this lip bumper in the lower arch. Why? Because I need to avoid the pro-inclination, is the unwanted movement of the mandibular advancement, the pro-inclination of the incisors. So in these cases, I use this lip bumper solution. But what happened in that case? In that case, I have in wanted result is I have more pro-inclination. So maybe that case, if I started, I put the lip bumper in the upper arch for the same, for the anchorage and to avoid the pro-inclination of the upper incisors. So I always say that in every case, you learn a lot. So in that case, I learned that I have another case, maybe in the future, if I will have a case similar like this, I'm going to use this lip bumper in the upper arch. So this is the upper arch, or the upper arch. This is the previous, the intraoral pictures, and this is the aligner number 27. Okay, but the patients need, okay, come to the office for the pre-refinement. So the pre-refinement sometimes is very complicated to explain the parents, because the parents say, okay, Dr. Vicente, and right now, what do we do? Because right now it's not perfect the case, but it's near from be perfect, because the alignment of the teeth of the lower arch is perfect, the upper is perfect, the lateral incisor right now is in eruption, maybe the lateral incisor, the tooth 12 right now have a lot of space, but sometimes you need to do something because the patient is not 1 year of treatment right now. So in that refinement, maybe in that case I start to incorporate that the tooth 22 to maybe to rotate and to put in the right position, and maybe in a pontic or maybe a compensation eruption pontic in the right side for the 12, for the tooth number 12. But my case is near to finish, and you can see like the difference between the arch from the beginning right now. And another very important thing is very, very important for me is like by the end of the treatment, we achieve this bilateral alternating mastication. This is very, very important. So you can see like the end of the first phase, though right now the patient have this already bilateral alternation mastication. You can see here in the right and the left, the frontal angle of the mandibular plane are practically balanced and symmetrical in both sides. And this is very important because the patient have this bilateral alternating mastication. And this is like the intraoral scanner from the beginning, aligner 27, and the previous from the pre-refinement. You can see like the quantity of the expansion in the upper arch, of course, and the lower arch as well, and the predictability that we have the expansion with these kind of solutions. From the beginning to the pre-refinement pictures. And of course, what happened with the profile? Of course, we improved the profile. So right now the profile is better because you can see that the first picture to the left is from the beginning. The middle is with the patient is the liner 27, and in the right is the previous from the pre-refinement. So that right now we improve like the profile. Right now it's a very beautiful profile. And right now we have like only to make maybe some changes like better alignment. Sometimes I prefer, for example, to leave 0.3, 0.5 millimeters mesial to distal of the primary of the baby canines to have this primate space for when the patient changes for the teeth. But at the end, we finish the case. So it's very easy with all of these solutions. And I always say, what happened with this case? No, I asked before, no? What happened with this case I treated 20 years ago? But maybe my treatment plan will be very different and more complicated. Right now, it's more easy, of course, more predictable. And this is like the webinar. So my idea is in this 1 hour of webinar is like to explain all of you this solution, in depth that case. And of course, if you have any questions or something like this, please, now is the time to answer your questions. You can, for example, if you want to write in the chat. Okay, I have a Carlos. Hey, okay, I have a class 2 division 1 skeletal case. The patient is an 8-year-old boy with a deep overbite, deep QSP, and prominent overjet, pro-inclined hyperincisors. He is ill for TB, but I am concerned about his non-compliant and he's too young. So I delay my treatment. I'll let him grow and mature a bit. Maybe tell him to come after 2 years. What are my other options to treat this case? Good evening. Okay, Carla. In my opinion, I prefer to you have a class 2 malocclusion. I prefer to start when I see. So, and normally and this is an articles published that they say that between 7-8 years old, this is a growth sometimes better than the pubertal growth. So at the end, I have my patient with 8 years old. Of course, I put this in this case, the indicate, of course, is the twin block because you say it's class 2 division 1, you have deep overbite. So if one of the characteristics is very important, of course, deep QSP. So the ideal is the twin block. Maybe if the patient have a not very good compliance, you can say to the patient, okay, use, for example, because the ideal, and the professor Genshin philosophy is used to during mealtime. So during mealtime, sometimes it's very complicated. It's very complicated, at least in growing patients. For example, in my GS cases is the special package the Smartee has for adult patients for mandibular advancement. For my adult patients, I don't negotiate. So I say you need to use mealtime. So it's mandatory to use 24 hours per day. So it's very, very, very important in adult patients. In growing patients, of course, they can remove the aligner during mealtime. So, for example, it was my patient. I say, okay, I put the twin block, use during all the day, and you remove during mealtime. And if the patient have a problem with the compliance outside home, because for example at the school have a no good compliance, maybe I say, okay, don't use at the school and use only at home and of course during nighttime. So I prefer to start because if you wait 2 years, of course, like in 24 years ago, when I finished my postgraduate program, I remember that my professors, they told me that it's impossible to make mandibular advancement in adult patients and in growing patients if they will very young. So it's only in the growth in the pubertal growth. So right now for me. I treat all my patients. It doesn't matter the age. If they need mandibular advancement, I treat it. 6, 7, 8, 9, 10 years old, 53 years old. So it doesn't matter. So in my case, please start the case. It's the best for your patient. Okay, David say, okay, what is the maximum age for maxillary expansion? Okay, it depends, David. For example, if you're thinking about is maxillary expansion from a skeletal expansion is 16 years old, but for a skeletal expansion, my recommendation, of course, is the patient have more than 11 or 12 years old. If you are maxillary expansion, oh no, if it's a very compression of the maxillar, use a Hyrax. For me right now is the Hyrax or maybe the Marpe. Marpe is another with mini screws, but the maximum age for maxillary expansion may be 16 because in 16 years old, like the palatal suture is closed. Will be closed at 16. So normally, if the patient is young, like 8 years old or 7 years old, my experience, but it's my clinical experience. It's not my science. It's not my science. It's my clinical experience. We can do this maxillary expansion with this kind of devices, and of course with the re-education of the position of the tongue. So it's very important, like the position of the tongue, because the best expansion of the world is the tongue. So it's very important to put the tongue in the right position for the expansion. They say, when do you still use fixed expander? Yes, of course. It's like I say, normally for example, in patients that more than 10, 11 or 12 years old with bilateral crossbite, I use the fixed expander, like the Hyrax or McNamara. It depends of the pattern, of the growing pattern. Normally it's like the mesophacial or maybe it's brachyfacial, I use like the Hyrax. If the patient is dolichofacial, normally I use like the McNamara. because you have these posterior blocks to help you to intrude, to correct this long pattern, this dolichofascia. But yes, I still use in that cases. Okay, Silvia say, hi, Dr. Vicente. Thank you for your doctor. Thank you, Silvia. For biplane, what is the difference again between anatomical and non-anatomical biplane? Which is of them will be used? Okay, this is a very good question, Silvia, really good question. Of course, like the non-anatomical is the anterior is flat. Is for example, in cases the patient have normally this class 2 division 2 malocclusion with increased overbite and retroinclination, and you prefer like the mandibular is free to the movement. So the non-anatomical is totally flat. So it's totally flat. The other, like the anatomical is normally is like you have like the position, you put like the incisor, the lower incisor, exactly what you want. So for example, you say to the technician, because it's mandatory to use like in that case like the scanner with the wax registration from the ideal position. So maybe in center relationship on that case, vale, in the position that you want to move the mandibula. So you have this dental impression for the edge of the lower incisors in the exactly position. So it's to move the mandibula in the exactly position. So when each of them will be used, normally I prefer to use like the non-anatomical, flat, because I prefer to be the mandibular free to the movement. So I prefer normally non-anatomical. Okay, Lian say, what's the youngest age to use S11 to expand? The youngest age is the youngest age the Smartee is like they provide you is like the 3 years old. So if you want to imagine you have a patient with 3 years old, of course they all if it's temporary dentition, it's baby dentition, but you have a very compression of the maxilla, you can use the S11 because even the Smartee Teen and Smartee Kinder, you can start the cases always from 3 years old. So the Smartee Kinder is 3 until 10 years old, and the Smartee Teen is from 3 until 16 years old. But the difference is in the Smartee Kinder is 2 years of management, is natural years, and in the Smartee Teen is 5 years, but it's 5 years of treatment, no management. So you can post-try, so you can use first and second. The youngest age is 3 years old. Of course, normally I don't use like these devices in 3 years old. I prefer maybe more than 4 or 5 years. Why? Because they have more confidence and they have more compliance. Okay, David say thank you, doctor. Carla, thank you as well. So Honor, they say, hi, Dr. Vicente. I have a 12 years old female patient with an overjet of 13-14 millimeters and deep overbite and retroconnecting mandibula. What is the aligner plan suitable for this case? Is mandibular expansion possible from begin plan for orthodontic surgery from orthodontist when she is adult? Of course, you have a break, of course, with this kind of the overjet with 13-14 millimeters, of course, it's a very big and 12 years old. So if you want to make the expansion of the maxilla with this, in fact, I have a case because we don't have time to see that case, but it's similar. It's a patient with a not that kind of overjet. It's near from 7 millimeters, 6-7 millimeters of overjet, at very narrow arch with a triangular arch form. So I put like the S11 solution for the expansion. At the same time, I use like the SH. In this case, is if you have increased overbite, you need to use like the twin block. If you don't have the increased overbite, you need to use like the herps. So what happens when you have more than 10 millimeters? If you have more than 10 millimeters, you normally in a Smartee is like when you use like the previous myofunctional or the previous functional appliance for mandibular advancement, like the twin block appliance, or maybe the herps appliance, or the Teuscher appliance, or clamp, or Bionat, or something like this. Normally is doing only one step. So maybe with an Invisalign, we start to make this during 8 aligners, we make 2 millimeters of advancement. But the theory and the science behind this say is better only one step. But one step of 14 millimeters is crazy because the patient is very uncomfortable and they have a lot of pain. So my idea in that case is I make two different steps. So I say to the technician or by myself, I make this wax registration from maybe from the beginning with 7 millimeters of the mandibular advancement, 7 millimeters, and I make my first treatment plan with 7 millimeters. And when I achieve my 7 millimeters, when you finish and you correct the 14 to 7 millimeters, and right now the condyle have the remodeling of the condyle, and right now the mandibula is in the right position because you try to put back and it's not possible because you have this remodeling of the bone, you start to make this new scanner with new wax registration and you correct the another 7 millimeters. So indeed, in that case, is more than 10 millimeters. My recommendation is doing by two steps, 7 millimeters and another 7 millimeters. When you achieve the fifth 7 millimeters, you go to the next 7 millimeters. Okay, thank you for the thank you, G, thank you too. Sylvia, thank you for the answer earlier. For the smart TV to get H2H bite with treatment with mandibular advancement, then how to let it schedule to normal class 1 more occlusion. And there will be posterior open bite at the end, means why need to mention during the refinement. Really good, another really good question, Sylvia. Okay, it's different because, for example, if you have the normally in the maybe a lot of years ago with the traditional functional appliance for mandibular advancement like twin block or Bionat or something like this, we normally ask for the technicians to deal the technical is to make this H2H. But right now the H2H is not the final position. It depends from the previous malocclusion. If we have this class 2-1 malocclusion, in the class 2-1 malocclusion, the upper incisor are proncline. So I need to think about in the future, I need to retroincline the incisor. So when I make this registration, this was registration, I need to left at least 1 or 2 millimeters. Why? Because my mandibular advancement is here. I need to retroincline the incisor. If I make this H2H contact, when I start to retroincline the incisors, maybe I have two problems, or I will have two problems. The first one is like I have no overjet, so I not correct the proincline of the incisor. And the second one, if I correct the proincline of the incisor and I retroincline, I create an anterior crossbite. So in class 2 division 1, the ideal is to left 1 or 2 millimeters to retroincline the incisor. I have the class 2 division 0. Class 2 division 0 is like the upper and lower incisor are straight with the skeletal bone. So in that cases, we can make this H2H. But for example, what happened in class 2 division 2 malocclusion? Because my upper incisor are retroinclined. So I do my H2H. What happened? When I start to proincline, I have increased overjet. So in that cases, it's very important the wax registration is the final position if with 1 millimeter of anterior crossbite. Why? Because I make this wax registration, all my mandibular advancement is what that one position, I proincline the incisor, so I have my final position. It's different in class 2 division 1, division 0, or division 2. So if you are using like the TV, of course, maybe it's not mandatory, but it's a good thing. When you finish the treatment, you have to finish with H2H, with not H2H, with anterior contact. And the posterior contact, you need this open bite, this posterior open bite. Why? Because that means that you're doing like the right treatment plan, because this posterior open bite you are going to use for extrusion or maybe for the natural eruption of the posterior teeth to correct the QSP and to correct the overbite. So it's very important when you finish your treatment plan with the TV, it's very important from the patient have this anterior contact but no posterior contact. And in the refinement, of course, you need a refinement. You need to start to close. And it's not mandatory, and normally it's not necessary to use button and elastics, because this disocclusion of the posterior area is like a natural eruption. This is one of the reasons, like for example, in adult patients, where the adult patients start to use like the twin block from the beginning, when they use from during mealtime, they are very uncomfortable because it's complicated to chew with the twin block appliance. But what happened at the end? At the beginning is a problem, but at the end is a solution, because the patient, when remove the aligner, the patient has this edge to edge or this anterior contact and have no posterior contact, this open posterior. So what happened? The patient needs the aligner with the blocks to eat, to chew. So at the end, the patient, they say, no, doctor, I prefer to use my aligners to eat with the twin block. So this is the difference. Okay. Okay, thank you. Okay.
Yeah, thank you so much, Dr. Vicente. Thank you so much.
Okay, thank you. Okay.
Yeah, I think that's all.
Yeah, there's one more question, Dr. Vicente. For the case you show it used during this webinar, do you happen to measure the height or depth of the palatal bulb pre-treatment versus adult 25? Was there is any reduction? Not because the measure of the height of depth of the palatal bulb. No, I don't have this measure. I don't have this measure, but normally they have a reduction, because you know that normally that the palatal in the patient, they have an arch narrowing. Normally when you make the expansion, you have this palatal bulb normally to decrease. So I have no the measure, but normally isn't it reduction? Maybe in the literature, the many articles they say, and normally the another thing is the patient start to breathe better, because normally you make the expansion, the tongue have more space you have more space for the tongue, and normally you can, for example, to the breathe, because like the palatal of they start to decrease, and the patient have better breath. But this is like the literature. I don't have the measures. And they say, can C11 achieve skeletal expansion in US patients? Okay, this is my clinical experience. It's not science. Okay, it's not. But I think so. Maybe not 100%, but maybe in growing patients, maybe in patients with between 6 until 9 years old, maybe one of the expansion that we achieve is like is skeletal. Skeletal is not the same, like for example, like with the Hyrax, of course. Instead with Hyrax, you normally with the 50% of the expansion, normally is dental alveolar and 50% is skeletal. No 100% skeletal. Instead, even use Smartee with mini screws, not all the 100% is skeletal. Maybe 80% is skeletal, 20% is dental alveolar. So with the S11, if I need to, for example, to make like the percentage, something like this, is like maybe for me in young patients like 6 to 9 years old, maybe 30%, 25-30% is skeletal, and the rest is dental alveolar. Okay, Fran, they say, how often do you start with a Smartee Teen and then finish with normal braces in children? 5 years old is a long time for children. Finish with normal braces. Normally, if I start with the Smartee Teen, I don't finish with braces because I have the management of the Smartee Teen is 5 years. So what it means that, for example, imagine I start a case with a Smartee Teen with the same example, no? During the webinar. I started a case with 7 years old, and I start to do the mandibular advancement. I need 1 year and a half. When I finish my mandibular advancement and I correct this retrograde of the mandibula, I pause the treatment. So in my Smartee doctor, in the patient, I pause the treatment and I wait until the patient need to change every teeth. So the patient when finished to change all the teeth, I can to reactivate the case. So I have 3 years and a half more years with the warranty of the treatment plan. So normally I continue with braces. I continue with aligners. Normally I don't use braces. In fact, right now in my day by day, my clinical, I treated my 80% of my cases with 80-90% of my cases with clear aligners. Only 20% of my cases with braces. This is including adult patients. In adult patients, normally in growing patients, I prefer aligners a lot. even in those cases that the patient is not have no compliance, is very complicated patient, have TDAH or something like this, I put braces. But normally, if I start with aligners, I finish with aligners. Yes, of course. This is you, Angela. Yes, we have another. Yeah, we have another seminar next, another webinar next week, next Friday.
Okay. Yeah. I think that's for all. Thank you so much, Dr. Vicente. See you next week. Thank you so much.
Thank you, everyone, and see you next week.